5, 4, 3, 2, and 1.
Good evening, everybody. This is our further session, live session on clinical presentation by undergraduate. Today we are discussing exam thyroid in a patient with the toxic thyroid. I welcome Professor Muthukumaran sir from Savita Medical College. I welcome sir very much. I welcome Professor G.V. Manoharan sir from Vinayagara Medical College. I welcome Robin George, Professor from Tiruvalla Medical College. I welcome Dr. Professor Keshav Prasad from Mangalore, actually from Medical College Sulya. Keshav, welcome you. Robin, welcome you. I welcome Professor Ganesh Kumar, HOD from Villapura Medical College, Tamil Nadu. Welcome you, sir, very much. I welcome students Sai Shruti B and Sangeeta A from Government Villapur Medical College. They are final MBBS students. They are presenting the case today. I welcome Manjul to YouTube. Sir, good evening, sir. I welcome Manoharan, sir.
Good evening, sir.
Sir,
Good evening.
Good evening, sir.
Muthukumar, sir. Good evening. Robin, good evening.
Yes, sir. Sir, we already online, sir.
Yes, sir.
Everybody, welcome Manoj, sir. Everybody, Keshav, Ganesh Kumar, sir, Robin, Muthukumar, sir, students, and all students who are joining the YouTube and eventually going through these sessions. Without wasting much time, we'll straight away go ahead to the presentation, sir.
Yes.
I think so. With Sangeeta, you are presenting the history, no? Sangeeta, Sai Shruti, who is presenting history?
I am presenting this to Sangeeta.
Okay, start.
Good evening, sir. Good evening to all the respected faculties present here, and thank you for giving this opportunity to present the case. Myself, Sangeeta. I'm final year MBBS medical student from Government Villapura Medical College, and my co-presenter name is Sai Shruti. She is also final year MBBS and from Government Villapura Medical College. I would like to present the case.
Yes, please.
Let's start.
On the next slide.
Okay, a 56 years old female, Mrs. X, who is a homemaker, came from Dindivanam and came with chief complaints of swelling in the front of neck past 1 year. Chief complaints of swelling in the front of neck for past 1 year and history of presenting illness. The patient was apparently normal before 1 year, after which she noticed a swelling in the front of neck, which was insidious in onset and initially small in size and gradually progressed to attain the present size. And it is not associated with pain, and no history of fever, no history of any other swelling, no history of dyspnea, no history of dysphagia, no symptoms suggestive of Horner's syndrome, no history of change in voice, and no history of syncope. And there is history of excess sweating, palpitations, sleepless nights, tremors. No history of loss of weight in spite of good appetite, no history of heat intolerance, no history of diarrhea, no history of muscle weakness, and no history of dyspnea and exhaustion, no history of oligomenorrhea. No history of weight gain in spite of poor appetite, no history of cold intolerance, no history of easy fatigability, and no history of constipation, no history of menorrhagia, no history of sudden increase in size, no increase of loss of weight and loss of appetite, no history of bone pain, no history of jaundice, no history of cough with hemoptysis, and no history of headache, convulsions, seizures. Past history. No history of similar complaints in the past and not a known case of diabetes, hypertension, tuberculosis, asthma, epilepsy, jaundice, ischemic heart disease, and no history of radiation exposure to the head and neck region, no history of surgery done in the neck, and no history of chronic drug intake. Its personal history. Patient consumes mixed diet, not a smoker, not an alcoholic, consumes iodized salts, no history of excessive intake of goitrogens. Family history. There is no relevant family history. Menstrual history. Attained menarche at 14 years of age. Normal flow of regular cycles 4/30 days. Not associated with pain and clots. Attained menopause at 45 years of age. Marital and obstetric history. Married for 28 years and it is a non-consanguineous marriage. Parity index is P to L2. Both are delivered by normal vaginal delivery and both are healthy and attained milestones according to its age. History of sterilization done before 25 years. History summary. A 56-year-old female, Mrs. X, came with complaints of swelling in the anterior aspect of the neck for 1 year, which is insidious in onset, initially small in size and gradually progressed to attain the present size. History suggestive of hyperthyroidism with no history suggestive of malignancy, probably a case of thyroid swelling under evaluation. I would like to proceed with the examination.
No. Wait. We'll discuss the history. Go back to the history.
Yes.
Next slide. Anything to comment on the Robin?
It's not audible.
Robin, you have to unmute, Robin. Robin, you have to unmute.
But the static at the background, some noise, not sure what.
Sangeeta, can you just off your mic for a few seconds? Yeah. Now it's better.
Maybe fan. Chief.
Robin, any comments?
No, here it's okay, sir. It's okay. Next slide.
Slide, okay. Swelling in front of neck, which was insidious, initially small inside, it was not associated with the pain. This what? Why pain? Why you have asked pain, Sangeeta?
Sir, to rule out any thyroiditis condition, any hemorrhage into the gland.
For that, one more thing, when you tell not associated with pain, because it's 1 year duration, no? So you should also tell pain when the swelling started. That is also important. Or sudden onset of pain. There is again the difference, when there is a hemorrhage or something like that, there is sudden pain. So not just...
Anything else positive? History-wise.
Sangeeta.
Swelling, palpitations is positive, sir, and that
That is a next
excess
disease. Why? Why fever? Why dyspnea, dysphagia?
So dyspnea due to any in case of compression of trachea cause dyspnea. Dysphagia to rule out compression of esophageal compression. This produce dysphagia, sir.
All it
All
has.
symptoms they will have in Horner syndrome. In which symptoms you will ask?
So in Horner syndrome we have ptosis, meiosis, anidosis, enanthalmus, and severe spinal reflex, loss of severe
So these are
spinal.
the
All
features.
five
No,
types.
patient won't be knowing all these features. What symptoms do you ask?
Sir, symptoms is hoarseness of voice.
It is for Horner, not Horner syndrome. Okay. Why syncope?
So any compression to carotid artery will produce reduce the blood supply to the brain, so it will cause syncope.
Okay, Robin, you have got anything to say that, Keshav? Cause for syncope is sir, Manoran sir.
Yes, sir.
compression causing syncope is little far-fetched, but
Yes, sir. Routinely need not be told.
because
Routinely you need,
we see so many patients with huge thyroids, no?
but no syncope.
Like that, they should go on fainting every now and then. That doesn't happen.
Very rare, ma.
Very,
So
very
I think you put the pressure symptoms in one order and then go for the other things. Okay.
I think she mentioned everything to rule out the possibility of malignancy.
Malignancy.
Yeah, that's what she's
Dyspnea,
telling that
dysphagia, hardness, change in voice, syncope, everything to rule out malignancy.
to roll out malignancy. That is accepted. It's accepted.
But
Categorize wise pressure symptoms first and then go for symptoms of malignancy.
Malignancy.
Like rapid increase, change in.
Okay, sir.
after this negative history, you are going to mention a positive history.
Some more are there, I think, sir, in the next slide.
Next
There are a lot of
slide, we are
negative
going to
history.
mention some positive history. That should be here.
Sanjita,
Okay, sir.
Sanjita, is there
Okay,
a fan, background fan or something? There's a lot of noise. Can you, we can't make out the, can you
Some
just check
problem with the background. It's
I
okay.
think it is
background? Yeah, a lot
Okay.
of static somewhere. Can you please check? Yeah.
Yeah. Now put on your this one. No problem. Put on
On your mic.
next slide.
Okay, sir.
Yeah.
Better.
better. Okay.
Now it's
Sangeeta, when you present a case, the site of the swelling, onset, incidence in onset, but when did it start? Like sir has said, when did it start? And initially small in size. What is small? How do you describe small? Either a patient's own words or something you describe, small, some fruit or vegetable. From when did it, and to attain the present size? So it's not specific.
Yeah, that's what.
Yes.
So in DAS, what they've written is either that or two, you explain as in finger breadth. Yes, either see you can patient's own words. They will say they'll use fruits, vegetables, something like that. But in DAS, you can show it to the patient and say, is it like this? Then did it become like this? So finger breadth. So
Yes.
because we are not sure what was it before and what did it become now.
So how long it
Okay,
took? How much time it took to become like this? So some approximately some dimensions you have to tell in the patient's own words.
Because
What-
the evolution of that goiter formation is what we are looking for.
Okay,
Evolution.
sir.
Yeah, because swelling is very important. That is one paragraph.
Yeah.
Then, like sir said, that straight away not associated with pain. She has only one complaint, the swelling. Nothing.
Swelling and excessive excessive sweating and
Please go to the
palpitations.
next slide. Next slide.
Next slide, next slide.
So positive, the main chief complaints first, then negative. Yeah.
Yes.
Next slide. Okay, now she has told actually setting palpitation, sleepless night, tremors are present.
What is the duration?
Now, what is the duration? You should have put in the chief complaint, no? Whether swelling
Yes.
appeared first and these symptoms appeared later or same time.
Online class.
So symptoms is for not for 1 year, sir. Like recently only symptom present, sir.
Sorry?
Excessive
What-
sweating, palpitations.
What is the importance of these symptoms in relation to the swelling? Why we are asking this?
Sir-
Sir has asked a very good question because the duration or the relation to the swelling to these symptoms is very, very important to differentiate between two important diagnoses.
And the palpitation
Primary
you can
and
put in the-
secondary.
palpitation you can put in the
Yes.
chief complaint.
Very good. Primary and secondary.
Correct.
But again,
Correct.
excess sweating, palpitation, all these things did not start simultaneously.
Yes, sir.
So one by one, things would have happened. So that you have to
Yes, sir.
ask little more detail. Which one started first or which she noticed first?
Now, can you tell us whether these swellings started later or the swelling before the swelling?
Symptoms appeared later.
Symptoms,
So
which one
after the
appeared first?
after the swelling only that symptoms are started, sir.
How
First
long
was the
after? Any idea?
so she tell like recently for 20 days only like that.
Like that, it is
Excessive
for 20 days.
sweating,
That is very
palpitations.
crucial.
Yeah, actually you should have put like this, palpitations and tremors for last 20 days. The chief complaint.
Okay, sir.
So understood, chief complaint. After swelling, put this one. So something has happened last 20 days. Even the swelling was there last. That gives a clear idea.
Okay,
Keshav is Robin is telling. Understood? No, Sangeeta.
okay, sir.
Okay. So no history of loss of weight in spite of good appetite. Okay. No history of heat intolerant, diarrhea, muscle weakness, dyspnea, exhaustion. Why muscle weakness?
So in case of any in case primary thyroid toxicosis or a condition that cause myopathy, so
Which muscles will go for myopathy?
How you ask the history? What question did you ask the patient?
Just muscle
it's a
weakness
body
or-
pain.
Body pain doesn't
Upper
mean
limb.
weakness.
Upper limb.
Okay, sir.
What question they will ask? The which muscle? The distal muscle or proximal muscle?
So like approximate.
Proximal muscle. So while getting down the step, they will find difficult, or lifting the bucket water. They
While
find
getting up from squatting position, that is a classical history they should give.
Yes.
they'll find difficult from getting up the starting position. Absolutely right. That's what Keshav is telling. You should ask specifically like that. Otherwise, you won't be
Yes.
able to get a proper history. You should know what history to be asked. To get that, there is proximal myopathy. Okay, or
Okay, sir.
lifting the bucket or some weight, or getting up from the squatting. That is a very good method actually. Okay, getting up from the
Okay, sir.
position. Okay, to say it is proximal myopathy. Okay, dyspnea on exertion. Why dyspnea on exertion?
Sir, any cardiac
When there is a cardiac manifestation,
cardiac move. So
oligomenosis.
this means.
Okay, understood. That is thyroid function. So anything to ask, sir? Manohar sir, Robin, Kumar sir, Ganesh sir, Keshav?
It's okay, sir.
In this slide, you wanted to rule out primary thyrotoxicosis or secondary thyrotoxicosis?
Sir, both primary and secondary.
What is the difference between primary and secondary? Which system?
So primary thyrotoxicosis usually affects the CNS attacks, but secondary means usually CVS cardiac system get affected, sir. And primary there is a no long-standing history is not present, sir. And secondary there is a long-standing history of a goiter like is present.
Correct. So CNS manifestation and CVS manifestation. You mentioned CVS manifestation. That is dyspnea and exertion. What kind of a CVS manifestation you can get it in secondary thyrotoxicosis? Pathology.
Sir, palpitations, dyspnea and exertion.
No, sir. Ask pathology, I think, sir.
Cardiology, cardiac manifestation.
Cardiac manifestation.
One is what you said, red. So there will be tachycardia.
Tachycardia.
And you said there is palpitation. What does it mean?
Sir, increased blood circulation, hyperdynamics.
Force of contraction.
Contractions.
And that is why patient is able to feel his own heartbeat. That is called palpitation. Okay, the force of contraction is increased, rate is increased. Anything else?
After that, what happens?
Other thing is
That hyperdynamic circulation will present as hyperdynamic circulation, so they present as bruit or something.
After that, what happens?
In cardiac, any other
cardiac manifestation.
Any other things you will come across?
cardiac manifestation.
So tachycardia, palpitation, ectopic beats.
Ectopic
Beats.
beats. Arrhythmias.
Arrhythmias.
What arrhythmia?
Sir,
Remember the conduction pathway. That is the clue. Where does it start? SA node, AV node, bundle of peace, no?
yes, sir.
So somewhere there is a problem. So what is the SAR is asking?
Which arrhythmia sir is Muthukumar sir is asking.
Sir,
Rhythm abnormality. What rhythm abnormality you will get? After tachycardia, what rhythm abnormality? Atrial fibrillation. Atrial fibrillation can lead to
irregular pulse. Irregular rhythm.
Rhythm. Very good. It leads to what? Next stage.
So it leads to cardiac failure.
Cardiac failure. So you have to mention the symptoms of atrial fibrillation, cardiac failure, and other things. The patient can have chest pain, syncope. Because of cardiac failure, she can have abdominal distension, pedal edema. If you mention all these things, you will be covering both primary and secondary.
And that's why they will have the history of dyspnea on exertion. Okay. On exertion, it seems it's a cardiac cause. Dyspnea on exertion. Okay. So we go to next slide, sir. Next slide.
Yes, sir.
On the next slide. Next slide. no history of weight gain, no particularly constipation, menorrhagia. Why constipation? Keeping what in mind?
Sir.
Why constipation? No history of constipation you have mentioned.
Sir,
That's why you
decreased
told diarrhea.
metabolic. Yes, sir.
Which condition you get constipation in thyroid? Hyper or
Sir,
hypo? Hyper or
hypo condition only constipation.
Hypothyroidism. You repeatedly have mentioned that no history of weight gain in spite of good appetite. That is coming in the second slide also. But actually, when what is the effect of excessive thyroid hormone in GI tract?
Sir, this will.
What is the classical history? Somebody is having toxic thyroid.
Sir, diarrhea.
Not diarrhea. Something else. Frequent stools.
Frequent stools.
Because of the increased rate of peristalsis.
Okay, sir.
The diarrhea is not a diarrhea of other causes. It is the frequency. Increased bowel movement.
Movements are more.
Okay, sir.
The difference actually. Okay.
So this paragraph, you try to rule out the possibility of hypothyroidism.
Okay, sir.
Correct?
Yes, sir.
No. Then you said no history of sudden increase in size, no history of loss of appetite, loss of weight.
So sudden again jumbled up. Sudden increase is for malignancy.
Malignancy. You started with the malignancy. Local effects of malignancy.
Sangeeta, you understand?
Effects of
Yes, sir.
You are jumbled up. Malignant features are different, then hypothyroidism is different, then the hyperthyroidism is different.
Sir, I started with pressure symptoms, sir. Next, I asked hyperthyroidism, sir. Next time, asked hypothyroidism, and finally, I asked malignancy symptoms. First, I asked that pressure.
This one probably she is mainly in relation to the metastatic malignancy. Because both pain, jaundice, coffin hemoptysis, headache, convulsion, dizziness, like that. But why loss of appetite, loss of weight?
Sir, rule out malignancy condition, any TB condition, lymph node enlargement, in case of.
Okay, because okay.
Generalized malignancy.
Because she is not yet confirmed that it is thyroid. That's why any neck swelling, so maybe related to that. That's what she is thinking.
Right. Next slide.
Next slide. Next slide. Lavanya, next slide. No history of similar complaint in the past, not the case of diabetes, hypertension, asthma, no history of radiation exposure to that and neck region. Surgery done with a chronic drug intake. Why these last three? What is the important last three sentences?
Sir.
What are the importance of last three sentences? Radiation exposure.
Sir, it didn't audible, sir.
Radiation exposure.
Why do
What
you
is
ask
important?
Radiation exposure to rule out in case it will leads to papillary carcinoma of thyroid. So,
what kind of radiation?
What kind of
sir, beta rays.
When?
Beta rays.
When radiation? 1 year back?
Sir, childhood radiation in case of any Hodgkin's lymphoma or
Yes.
any.
Okay.
So it is not recent. It should be childhood radiation.
Childhood radiation.
Childhood radiation. Long ago. It takes time to connect malignancy. Why surgery? History of surgery done in the neck is important.
Sir, to rule out any recurrence may be present in case of hemithyroidectomy does one side, it will come on the opposite side also. Does rule out a recurrence condition.
Okay.
And total thyroidectomy also.
Okay. With the to hemithyroidectomy or subtotal, golden day subtotal, partial.
Yes, sir. That recurrence, high recurrence.
Okay, accepted.
You mentioned about drugs. What
drugs?
What drug you are interested?
So lithium anti-thyroid drugs.
And lithium as it is anti-thyroid, but lithium as a what? Lithium is commonly used where?
So in case of
Not batteries.
Lithium is drug of choice for what?
Drug of choice for what? The thyroid or somewhere else, lithium is the drug of choice.
sir,
It's a drug used for mania, no? MDP.
Bipolar disorder.
Bipolar
Yes,
disorder,
sir.
Psychiatric drug.
mania, the drug of choice, no? That's what
Okay,
this will go for a thyroid dysfunction. It also has got effect on the thyroid. Only lithium is used for this by psychiatry. Okay, and
Yes, sir.
that will cause some thyroid disorder. Okay, so
You will always ask about any drugs, thyroid drugs,
Anti-thyroid drugs.
not necessarily anti-thyroid. Whether patient has been on thyroid drugs, maybe probably she's a known case of hypothyroid.
Yes.
hypothyroid is very common. In female.
That gland only will go for multinodular.
Thyroxine intake is quite common.
So you should ask always any history of thyroid intake.
Okay, sir.
How will you know that it is thyroxine or it is anti-thyroid drug?
How will know patient will say I have taken?
Sir, if thyroxine means they will take in empty stomach, sir. If anti-thyroid drugs means they have to take 3 times a day, 8 hourly. But thyroxine once a time only we have to take. So it also after food we have to take anti-thyroid drugs.
Absolutely perfect. Okay.
Next
Correct.
slide.
So next slide. Lavanya, next slide. Okay, personal history, not a smoker, alcoholic, consumes iodized salt, most of exit. What are the
So
Goitrogens.
goitrogens
What is
like
that goitrogen?
cabbages, brassica family, like cabbage, cauliflower, kale, raffe, mustard.
Okay. I think next slide. Family history, no relevant family history or anybody, nobody having any disease, thyroid disease or in the family, is it? You have asked in detail.
Sir, case of any autoimmune diseases, London family, Hashimoto's thyroiditis, or medullary carcinoma of thyroid, Men's syndrome, London family. So,
Why medullary carcinoma thyroid you have brought in actually? Even thyroid as per se can occur in family.
yes, enzyme deficiency will lead to hereditary enzyme deficiency.
Robin, anything to comment on this? Manoj sir?
Endemic area.
Endemic area.
Yes.
You mentioned
Endemic
Villapuram.
area, family people will have thyroid. That's the point.
Yes, sir.
Told iodized salt they are using. So
Remember any syndromes associated with family, ma? So a lot of cases, types are there. We have a lot of, as you said, men's syndrome, then medullary, then anything else?
Anything else?
any
Family.
What is the thyroid disease, breast disease, and so on? Put on your mic.
Sir, Cowden syndrome.
Cowden syndrome. Okay.
One more is dysharmonogenesis.
What is dysharmonogenesis? Sir, it's likely pointed out. Have you heard about it? Dysharmonogenesis.
Sir, enzyme deficiency will lead to dysharmonogenesis, sir.
Enzyme deficiency.
Like
You'll have very large goiter, soft goiter. But once you take thyroxine, these goiters are significant. Anytime they may not require surgery in such situations. But very large goiter because enzyme deficiency. Okay, this is the dysharmonogenesis. Right, agreed. Next slide. So, okay, this is important actually. Sir, anything to comment on this, Manoj sir, Keshav, Kumar sir?
Nothing, sir.
Nothing, sir.
Okay, okay. Next slide. History summary, complete swelling in the anterior neck gradually progressed to attain present size. It is suggestive of hypertrophic, no history suggestive of malignancy. So, no history, whether it's should add on to no history suggestive of malignancy at this juncture, we are not sure, just you tell. Probably a case of thyroid swelling under evaluation. That is okay.
No, with this background of all these symptoms, you want to call it as hyperthyroidism.
But you are not mentioning the palpitation is present. There is palpitation, is that history of palpitation, tremor, and diarrhea present, you said. Some
So
symptoms are
palpitation.
history, no?
Yes,
But you
sir.
did not mention the summary. You
Yes,
have mentioned at least palpitation and tremor. That's important. Okay.
Sangeeta, you only told cardiac manifestations are there.
Yes, sir.
Then with palpitation and tachycardia, that means you only said it is probably secondary hypothyroidism. Isn't it?
Yes, sir. Yes, sir.
Then is primary or secondary means you said it is secondary. Now you are telling it is suggestive of hyperthyroidism.
Okay, sir.
Is there any difference between hyperthyroidism and toxicity?
Sir, like hyperthyroidism is one of the cause for toxicity.
Thyrotoxicosis is, it can be due to thyroid or due to something else, wherever thyroxine comes from. Even drug induced or
Yes, sir.
other process, in other areas, metastatic disease can also cause sometimes thyrotoxicosis. When you say hyperthyroid, you are committing that disease from the thyroid itself. Okay. So here you have to add down to the palpitation in the summary. Important. Okay. And even chief complaint you have to add on to palpitation. If present, if you are not added, it's what we discussed
Yes,
about 3 days. So that is very important because to differentiate when a patient has become toxic, earlier patient might
Yes.
not have been become toxic.
Sangeeta, one question. From
Yes,
the
sir.
beginning, you have been telling there is a swelling in the front, in the anterior aspect of the neck, and you have come through all this narration. Why do you say it is thyroid?
Sir, because of its location, sir, because it present at midline in anterior aspect of the neck in a thyroid region, also present between the two anterior border of sternocleidomastoid muscles, sir.
That
And
is the region of thyroid.
In the region of the
Yes.
thyroid.
Region of thyroid, plus it moves with deglutition and does not move with.
protrusion of tongue.
That defines this is what you are talking about is thyroid.
Yes, sir.
But,
Yes.
what that comes in the examination, probably they are
But I'm just telling. From the beginning, you have been telling swelling.
swelling.
And we have come to the summary also. So,
So palpitation
Yes.
is important thing you have to add on to, which you have not added, but you have mentioned in the history. But summary
Okay, sir.
and chief complaint you should add on to it. So we will go to the examination, sir.
yes, sir. Yes, sir.
So next slide. Sai Shruti.
Yes, sir. Can I start, sir? After explaining the procedure, verbal consent was obtained in patient's language and patient was examined in the Wenlock room under adequate exercise in sitting position. Patient was anxious and was conscious and oriented. Patient was comfortable and cooperative, moderately built and moderately nourished. No pallor, no itches, no cyanosis, no clubbing, no fetal edema, generalized lymphadenopathy. Eyes and skin were normal. Vital examination, pulse rate 110 beats per minute, which was regular in rhythm, normal in volume and character, no radioradial or no radiofemoral delay. BP 120 by 80 mmHg, measured in left upper arm in sitting posture. Temperature 19.6 degrees Fahrenheit. Respiratory rate 16 breaths per minute, thoraco-abdominal type. Head to toe examination. Hair was black and lustrous. Face normal, no facial cluster, no peripheral loss of eyebrows. Eyes were normal. Oral cavity, no macroglossia, no lingual thyroid or tongue tremors present. Skin normal. Upper lip fine tremors present. Palms were soft and not moist. Lower lip normal, no pretibial myxedema. Local examination, inspection, examine in the sitting position with neck extended after exposing from chin to the upper chest. A butterfly shaped swelling over the anterior aspect of the neck measuring 4 cross 3 cm, extend upper border 1 cm from the hyoid bone, lower border 2 cm from suprasternal notch, right side close to anterior border of right sternocleidomastoid and left side close to anterior border of left sternocleidomastoid muscle.
Next slide.
Next slide.
Surface appears to be nodular. Skin over the swelling appears to be normal. Well-defined borders. Lower border visible. Trachea appears to be in the midline. No other visible swellings in the neck. No scars, sinuses, dilated veins, or visible pulsations. The swelling moves with deglutition. Pemberton sign negative.
Next slide.
Next slide.
On palpation, examined in the sitting position with the neck flexed, not warm, not tender, a butterfly-shaped swelling in the anterior aspect of the neck which moves with deglutition and with more prominence on the right side. Size of the swelling is measured to be 4 cross 3 centimeter.
Next slide.
Extent, upper border 1 centimeter from the hyoid bone, lower border 2 centimeter from suprasternal notch, right side close to the anterior border of right sternocleidomastoid muscle, left side close to the anterior border of left sternocleidomastoid muscle. All borders were well defined, lower border palpable. Surface is nodular, firm in consistency, skin over the swelling normal and pinchable. Plane of the swelling was deep to strap muscles. Swelling is mobile.
Slide.
Trachea is felt in the midline. Carotid pulsations felt equally on both sides. No palpable thrill. No palpable cervical lymph nodes.
Next slide.
Percussion. Resonant note felt over manubrium sterni. Auscultation. Bruise heard over the upper pole of the swelling.
Next.
Treatment.
Go back.
Antithyroid.
Wait. Go back to the inspection.
General examination. Just go back. Go back. Go back. Still back. Examination you have to go. Go back.
Yes.
Okay. Stop here. Next. Here. Okay, sir, anything to comment on that? Face is anxious, conscious, comfortable, moderate level to nourished, no cyanosis, no general information. Eyes and skin normal.
So you can put it as no eye signs. In this case, it is.
No eye signs. You have to specify no eye signs.
You have to mention no eye signs.
Which are eye signs you are interested to look for in these patients, Sai Shruti?
Sir, eye signs that may give suggestions for primary toxicosis.
Okay, but which all eye signs you look for? There are around 20-25 eye signs, but you don't need to remember only few, around 5, I think.
Sir, major 5 eye signs: Darlimpi sign, Von Graffi sign, Selvac sign, Joffrey sign, and Mobius sign, sir.
Okay, what is Mobius sign?
Sir, Mobius sign is a late manifestation due to accumulation in the intraorbital space.
How will check it?
Sir, Mobius sign is seen when
How will do it? Check it. Clinically, I will check it.
What is seen? How do you?
I will confirm the.
How do you say it's positive?
Sign is positive. You put your finger like this, no? Then converge like this. Then you see the eye is converging or not. And sometimes
it's a loss of accommodation reflexor.
So whether they will have difficulty in convergence, sometimes they will face
convergence of eyeballs. Sir.
Yeah, suppose Mobius sign is positive, what it suggests for you?
Severe case of exophthalmos, sir.
They will go for ophthalmoplegia or something. It will worsen the eye vision and other things. It's actually a warning sign. Okay, so she's absolutely told same thing. Von Graves, Darlim's, and Mobius, Joffroy's, and Novziger. These are the 5 signs you have to remember. Nothing more. Maybe importance. Other signs are important mainly for MCQ purpose. But clinically, these 5 signs, if you remember, and you should know how to elicit, how to check these signs, and it's a clinical significance you have to know. Okay. So these 5 signs, I think. Correct, no, Robin? I think these 5 signs are important. They have to know how exactly to check.
Mild, moderate, severe. Okay.
Mild, moderate, to assess the exophthalmos. Okay. So eye signs you have to mention, right? Rightly, sir, rightly told. Eye signs are not present. It's not just eyes. Okay. So next slide.
Next slide.
So vitals, you said 110 beats per minute. What it suggests? Is it normal or not?
Abnormal, sir.
Means
Yeah, I
Means
have to quantify it more. No, what else? How is it abnormal?
Sir, it is a sign of hyperthyroidism, sir. It is more than
What is
110.
it called when it is 110 beats? What is it called?
Tachycardia, sir.
See, how many questions we have to ask to you to tell tachycardia?
tachycardia, no? Tachycardia is important thing. That's a very significant thing. Pulse rate, okay? BP is okay. Other things, Kryl's grading is there. Kryl's grading.
Yes,
Have
sir.
you all if you heard about no? Sangeeta,
Yes, sir.
Sai Shruti.
Yes.
Yes, sir.
Yes, sir.
one more thing, Sai.
Yes, sir.
Pulse will be, how will be the pulse when you palpate?
Sir, rate is increased, sir.
Ah,
It can be irregular, sir.
maybe. Okay. Then what else?
What else?
Sir,
What happens when there's hyperdynamic circulation?
Hyperdynamic, when you feel the artery, how will you feel?
sir,
Sir,
pulsation, tachycardic pulse will be present, sir. Pulsations will be high.
What
Volume,
Number,
What happens to pulse pressure?
bounding, no? Bounding pulse.
high volume pulse will be, sir.
Bounding thing. Bounding pulse.
Bounding pulse, sir.
So if you consider it's almost getting lifted.
Yes, sir.
Bounding pulse. So that you have to mention.
You go to next slide, sir.
Yes, sir. Yes.
In pulse rate, what is another thing that you need to ask in thyroid patients? What is important in pulse rate?
Sleeping pulse will be
Sleeping pulse rate, yes, one. What do you call that grading system?
mild grading
Right.
setup, sir.
Mild, moderate, and severe. Yes, very good. These are the last question in that because you were answering everything. What is the significance of the sleeping pulse rate? Why you want to check it?
Why you want to grade it? What it suggests first.
Why do you want it? Why? Because in the exam you won't get patients who are sleeping, but we used to do that before in the ward. Why do you want to check it? Why sleeping important?
Sympathetic activity will be measured well during sleeping, sir. That is why sleeping pulse rate is measured.
No, but why do you want to do it? Why do you want to?
Sangeeta can answer.
Sir,
Because
I
your
think
patient
it
is very
non-REM.
anxious, and that's what you said, no? On general examination, patient is very anxious.
Yes, sir. In
So-
case of sleeping times, usually sympathetic activity is decreased, sir.
Yes.
Parasympathetic
So-
activity only present. So the BMR is true BMR during sleep measured is.
So
All the
what do you want? What do you want to
basal
do?
rate. Call it as basal rate.
Basal rate is true B.
When it is measured exactly.
So during non-REM sleep at midnight in
Post-
2 a.m. to like that.
Right.
That is it's a more accurate method of assessing the pulse.
Because patient is not conscious. So all his olfactory, auditory, physical, all the inputs are not there. Patient is in semi-conscious sleep. So without stimulus, what is the basic energy required for receiving?
Even then it will be high, means it is definitely
That's why it is called as basal rate.
so that sleeping pulse rate is more accurate way of assessing. So tongue tremors, how will check?
Sir,
Tremors, spine tremor.
tongue tremors, we have to ask the patient to open the mouth and keep the tongue inside the mouth and should not protrude it. And we should check for.
Never protrude it down. That's all.
How would you look for the fine tremor in the upper limb?
We should ask the patient to keep the arms in front of him, and we should place a paper on the back of the arm, and we can look at the tremor.
Yes, very good. What do you call those tremors? What do you call those tremors when you ask the patient to extend like this and you?
Fine tremors, sir.
Fine tremors,
There are two types of tremors that you will see in surgical practice. One is fine here, and the other one is There will be coarse tremors.
Where will get coarse tremor? How would this fine tremor differ from that? Coarse tremors are only where.
There will be coarse tremors.
Coarse tremors, sir.
You have to ask the patient to keep like this, and
In manifestations, coarse tremors will be seen, sir.
liver failure, asterisk. Okay, fine.
It is outstretched hand. In the outstretched hand is important. You can put a paper or pen over the finger. That's important. Tritibial mixed edema you look for. What is that tritibial mixed edema?
The tibial mixed edema is non-fitting type of edema usually seen in hypothyroidism condition due to accumulation of glycosaminoglycans, sir.
Hyper or hypo?
In hypothyroidism condition, sir. Tibial mixed edema, hyper, sir.
Hyper. Okay. It is a misnomer. It is seen in hyper. Misnomer depression, both sides uniform from below upward, from the ankle to skin.
Any other edema?
Any other edema?
Any other edema? Fetal edema?
No, sir.
No. You said congestive cardiac failure, atrial fibrillation.
Cardiac failure edema will be there. It will be pitting, no?
Pitting edema.
Same patient can have a cardiac failure. You said exertion or dyspnea. In such a patient, they will have a pitting edema. That is that that's a congestive cardiac failure. Whereas this is the primary toxic. It's a feature of Graves' disease, where this pre-tibial mixed edema. So that's the difference.
Okay.
So both types of edema can occur in toxic thyroid, depending on the clinical situation.
Okay, sir.
So next slide. We'll go to the next slide, sir.
Yes, sir.
Now on the next slide. Okay. Either sitting position, but why butterfly shape would you say? This it's both side equal or one side more? This side
right
it is more.
Right side was more prominent, sir, but both side swelling was present, sir.
Okay. Anything to comment? Lower border you have mentioned, I think. Lower border she has mentioned. So. Lower border is most important thing in as far as boundary is concerned in thyroid. If there is lower border is not testing down, it suggests that there is a resistance. Keshav, anything to comment in this slide? Nothing, no?
So,
Sir,
but
upper part,
hyoid bone is not something that is seen on inspection, no?
Yes, that's what. Hyoid bone is palpable, no? It is not. You can't inspect the hyoid bone.
What is visible?
Even difficult to palpate, but
What is
You can
visible?
take upper bone. You can take some other bone point.
instead, see if you describe the lower border, if it's only 4 centimeters, you can say 4 centimeter upward. That is sufficient. But if it is really big, it is close to the mastoid or something like that, then you can say it is close to the mastoid. So easier to describe it that way.
Okay, sir.
I think that is correct because hyoid bone we won't be able to inspect hyoid bone. Even often difficult to palpate also.
Even thyroid cartilage, sometimes even in men, okay, sometimes you can see the thyroid notch. But in ladies, it is difficult to see the thyroid cartilage also. So those both things is not ideal, I suppose. Hyoid bone and thyroid cartilage.
That's absolute right point. So take some other point to when you describe the upper of hyoid bone. Put it on inspection. Sai, Shruti and Sangeeta. Okay.
Okay,
So, okay, right. So we'll go to the next slide. Robin, yes.
Yes, sir.
So next slide. Okay. Surface appearance nodular, inward swelling appear normal, well-defined border, no border visible. Trachea seen is it? Trachea is midline seen on inspection.
Sir, yes, sir. Trachea appear to be in the midline, sir.
Okay, no scar direct means pulsation. Everything moves with rotation. Then you should have put on inspection. You should have put movement illusion first actually. That's the most important thing. Most crucial thing is the movement of the rotation.
And you should tell moves upward deglutition.
Upward of the rotation. Every word is important, and that should come first actually.
Okay,
Which
sir.
swelling moves upward in the nutrition on while drinking water.
This is a thyroid swelling, so you should give points to say that it is thyroid.
Thyroid. So this point should come first.
So you have to mention moves up with declaration, lower border is visible. So you can mention 2 points about it.
That is important. Lower border.
You can add that it doesn't move with the protrusion of tongue also, you should mention that.
Okay, sir.
To differentiate between thyroglossal cyst. Always make it a point to combine.
3 points together.
When the lower border is visible, why you want to do Pemberton?
How to do that?
2 centimeters above the suprasternal notch you have mentioned.
Yes, sir.
Yes, no. But lower body is well visible. Then it is not retrosternal. Why very clearly why you want to do Pemberton?
How to do that? How to do that?
How to do the Pemberton?
We should ask the patient to raise both the hands such that it touches the ears, and we have to see for congestion.
Hand or arm?
Sir?
Arm is raise or hand?
The hand must be raised, arm must be raised such that it touches the ears on both sides, and we have to look for congestion of the face, sir, and the neck.
Keep it like that for 2 to 3 minutes, then you see the condition of face, dilated veins, and so on. That is the thing like that. Sir is showing exactly. Arm should not hand. Arm should touch the ear. Absolutely right. Thank you, Robin. Very right. That's difference is already shown. Not hand, it is arm. Okay. That's absolutely right. So that's how that they will do it. Next slide. Next slide. Next slide. The sitting position, neck not warm, not tender, bottom deep, not tender. With more prominence on right to be 43 centimeters. It looks bigger than what you are telling actually to me on this question. Sir, anything to this side?
Okay, sir.
Sangeeta Sai, patient is palpation. Patient is examined with the neck flexed, not warm, no local rise of temperature, no tenderness, not warm.
Not warm, not tenderness. Okay.
Yeah.
Okay.
And swelling, yeah, you measure it correctly because this time you are measuring it.
Next slide. Now on the next slide. 1 centimeter from the again hyoid bone mark taking as a mark.
We'll change that.
We have debated surface nodular firming consistency. Skin node swelling is normal, pinchable. Pain of the swelling deep to strap muscles. Deep to sternocleidomastoid muscle you can tell. Strap muscle. Swelling is mobile means what? What is that mean?
Which direction?
Sir, it was mobile both the horizontal and vertical directions, sir. It was not fixed, sir.
So this thyroid moves independently, vertically and horizontally, is it?
No, sir, no, sir.
Then
How does it
Fixing
horizontally?
of the swelling can be malmoved, sir. So mobility was on.
so not like that. Independently thyroid will not move vertically. It moves with the deglutition, during deglutition.
And horizontally also, as such, it doesn't have a horizontal mobility, no?
It moves along with the trachea. Okay, mobility is there. It will be there, but horizontally mobility will be there. Vertical mobility, it moves vertically during deglutition. Independent mobility will not be there.
Okay, sir.
I'm amenable for correction, Robin. Anything to add this word? So independently, I think Muthukumar sir.
Yes, sir.
So that mobility you have to further explain. If you are feeling it is mobile, no, you're not dealing it. Don't tell vertical mobility and independent horizontal mobility.
Really moves up and down with deglutition.
This is sufficient. Next slide. Next slide. Lavanya, next slide. Is belt in the midline, 30% felt equal on both sides. No pulse. Thrill where will feel?
Sir, due to upper pole of the lateral lobe, sir.
Yeah, why upper
due to
pole?
vasculature. Due to increased vasculature, sir, superior thyroid artery will be present in the upper pole, sir.
The branch from?
Thyroid artery is in the lower pole. Actually, main blood supply for a thyroid is by the inferior thyroid artery. Superior thyroid
Yes,
only 30 to 40% supply. Why not inferior pole? Why upper pole?
Sir, direct vasculature will be increased, sir. Increased blood supply, blood flow can be seen in the upper
Right.
pole.
Why
Inferior thyroid has
The turbo.
80% blood supply.
main blood supply is from the inferior thyroid, no?
Inferior thyroid.
Yes, sir.
Then why you want
There also vasculature will be increased, no?
actually will be increased in the superior thyroid also? What anatomical
Sir,
region in the upper pole?
It is a branch of the external carotid artery, sir. So direct turbulent flow increase can be seen in superior thyroid artery, sir.
That is okay. No, this thyroid or superior thyroid artery joins the gland in front, superficial, in front like this. Whereas inferior thyroid artery joins from posterior.
Posterolaterally.
Posterolateral, understood? No, where it joins in the superior pole in front. That's why you can feel the pain. It's anatomical distribution in front, whereas the inferior thyroid artery from the behind, actually posterior. That is anterior distribution, okay? Because of the distribution, anatomical location in the thyroid, okay? That's why you feel in the superior pole. Okay?
And superior thyroid is a leash of vessels. It is multiple vessels entering in the upper pole. Whereas inferior thyroid artery usually enters as a single vessel.
Okay, sir.
Okay, so go back. Okay, go back on. Okay, no thrill, no palpable lymph nodes, carotid pulsation felt, trachea is felt in the midline. I think all of you know how to check the trachea.
Yes,
Three
sir.
finger test, trail sign, all
Yes,
those things. I think it will be asked
Yes,
in the
sir.
exam. All of you know, should know all those signs, how to palpate, three finger checking. That is important, no? So, see, Robinson is actually demonstrating how exactly to check three finger. That is also important. You should know how to do that. So, lymph node. Why you want to check lymph nodes?
Sir, due to metastatic involvement, sir, to the central group of lymph nodes.
But central group will be able to feel it, is it? Usually, it is easier to feel central group of lymph nodes?
No, sir.
Primary lymph nodes?
Which lymph
Or
nodes you are
lateral
checking?
lymph nodes?
Sir,
Which lymph nodes you are checking for?
cervical group of lymph nodes, sir.
Oh, there are multiple groups, no?
Which group? No, you got level 1, 2, 3, 4, 5, 6.
Yes, sir. Level 1 submental submandibular.
No, in this patient, which group you
This
are
patient,
specifically looking for?
thyroid, which group, which level you will concentrate?
Anterior group of lymph nodes, sir.
Okay, but level you tell, no, which anterior, which level, you got idea.
Which level, ma? You know already level.
Level 3, 4, no? 2B, 3, 4. Okay.
Yes, sir.
So, there are the secondary thyroid lymph nodes. The primary thyroid lymph nodes are in the midline.
Yes,
Prelaryngeal,
Not palpate.
brachial nodes, and parathyroid. That is difficult to feel, primary nodes. Secondary nodes are we are concentrating. 2B, 3, 4. Okay.
Yes, sir.
Next slide. Next slide. Lavanya, next slide. Lavanya, next slide.
Lavanya?
Percussion, resonant node felt over manebrium sterni. Okay. Why you want Farkas?
Sir, to rule out retrosternal goiter, sir.
If there is resonant goiter, what will be the percussion node?
Sir,
If there is retrosternal extension, what is the percussion node?
dull node.
You heard, you said you heard over the upper pole, but there is no frill, you said.
Yes, sir.
Frill is not felt, but Bruce heard, is it?
Yes, sir.
Why Bruce heard?
Same reason, sir. Increased vasculature near the upper pole, sir.
Okay. Okay. Robin, anything to comment? Sir, Muthu Kumar, sir, Manor, sir. Okay. Next slide. Next slide. Lavanya, next slide. Okay. abdomen, pendular system, fine. Anything to comment on this, sir? Fine. Fine and clean in normal abdomen. Why? Which organs you are interested? Organomegaly is
Yes, sir. Hepatosplenomegaly can be present in primary thyroiditis cases, sir.
only in primary or in other conditions in thyroid can cause splenomegaly, other than Graves' disease.
That's all, sir. Metastasis may be present in the liver, sir.
I think in the liver, not in the spleen. Spleen secondaries are not known, very uncommon.
Okay.
Okay.
Yes, sir.
Hashimoto thyroiditis. They
Yes.
can have liver and mainly spleen enlargement.
Okay.
Hashimoto thyroiditis. Okay. So we'll go to the next slide, Robin. Next slide. Okay, summary, anything to comment, Keshav? Again, movement position, border will define mobile in all directions. I'm not, sir has to comment. Robin or Muthukumar sir, that mobile in all directions is it acceptable?
Not acceptable, sir.
Mobile in all direction is not acceptable. Sir. Thyroid is not mobile in all directions. It is not a subcutaneous swelling. It is rather deep. It is within the pretracheal fascia. Keshav, anything to comment, Keshav?
Yes, sir. I think, and some of the, of course, you should be knowing all the clinical methods to examine a thyroid nodule, like Riles and Lahays. We have not discussed that, but I think in a previous. So I'm sure you should be knowing all that because the questions can be asked about how to examine the patients.
Yes, the Leahy's method, Fizelos method, Riles method. All those methods are important. We understand that we should know how to do that.
Yeah, Cocker's test, laryngeal test, I think.
Cocker's test. Have you heard about Cocker's test, Sai? Right,
Yes, sir. Cautious step, sir. Lateral compression on the fascia may produce stridor, sir.
Lateral, okay.
What does it suggest? If it's positive, what does it mean?
Infiltration of thyroid or thyroid obstruction due to tracheal obstruction, sir. Infiltration of trachea or tracheal obstruction due to enlargement of
infiltration is different, compression is different. Infiltration is see that there is a malignancy. Tissue is going inside. Compression is pressure. Which one you are checking in Cocker's test? Compression or infiltration?
Compression, sir.
It's not a test of compression, not test of infiltration. Don't get confused.
So it suggests what? Cocker's test positive means what?
Compression of trachea is present, sir.
Why compression? Compression will be there.
What is it called?
Tracheomalacia, sir.
The weakening of the tracheal rings. Tracheomalacia.
Yes.
So
why is it important to know whether there is tracheomalacia or not?
Because after total thyroidectomy, the trachea can be will not be patterned, sir. So to maintain that, we have to first check the tracheal patency.
We should be prepared for tracheostomy if required.
Yes, sir.
The patient requires tracheostomy. Okay. How long tracheostomy is required? How long will keep the tracheostomy in such a patient?
6 to 7 weeks, sir.
Lifelong? Temporary?
It's okay.
So you can answer, because
I think it's only a temporary thing. Tracheomalacia, because of long-standing pressure, there is actually the large thyroid keeps the trachea patent. The moment you remove the thyroid, because of the air flowing through the trachea, it will compress, it will collapse and cause stridor. So we need to make a tracheostomy to keep it patent, and that's usually a temporary thing. And within 6 weeks, the tracheal strength will regain, and we can close the trachea again.
Absolutely. It's a temporary, not permanent. Okay. So again, important.
But we should be prepared. That is why it is important. We should be prepared, not only for the patient party also. We should tell.
I think you should mention actually in the palpation at least Leahy's method, Riles method, Fizelos method. None or not. Those words should come in your sheet. It is not. It was not there. So I think Keshav has reminded that and highlighted these tests. Basic few tests are important in thyroid. We will discuss it when you present a long case. It should be mentioned in the palpation on this. Okay, don't forget. Okay? So we will go to the Robin, anything to add? Muthukumar, Keshav has added nicely actually these points, important it is in here. These signs are important. You have to mention these, at least these basic steps, okay? So next slide. Now only next slide. Okay. Why you said toxic non-malignant multinoid regulator? Why you committed on as a non-malignant? Sir,
So
Muthukumar,
because
they should comment. They should commit right now only non-malignant. Is it right? Keshav? Robin, whether they can put it like that non-malignant now only.
Malignancy, how did you figure out?
Exactly.
Toxicity in multinodular goiter, you can figure out the non-malignant any features suggested.
If they ask malignant, unlikely you can tell. Otherwise, you put
The
toxic
focus should
multinodular goiter and keep quiet.
focus. Yes, focus is on toxic multinodular goiter.
You don't
Then if somebody asks,
require to you don't require to commit that it is non-malignant now only. Okay, that means you have made yourself sure that it is not malignant. Then you will not have any choice rather than picking something to that. Good. So just to keep a diagnosis toxic multinodular goiter and keep quiet.
because usually usually by statistically also when it is toxic, the chances of malignancy are not high.
It's less common.
It is less common to have
We can tell
functional
later.
malignancy.
But writing non-malignant toxic multinodular goiter is fair enough for clinical
Yes.
diagnosis without mentioning anything about as a committing as a non-malignant. Understood?
What about the secondary thyrotoxicosis, sir?
That the second also can have the malignancy also because
Secondary thyrotoxicosis.
this is what type also they should mention actually. Sir has told which type of toxicosis it is. Secondary, no.
second, yes, sir.
Secondary toxicosis they can have a malignancy also. Primary is very less association of malignancy. Secondary toxicosis they can have a malignancy association also because that's one of the complications in the existing pre-existing goiter it happens. That's what don't commit as a non-malignant.
Non-malignant.
Commit just to tell non-toxic multinodular goiter. Understood? The point is very clear. Unnecessarily don't commit and put something inside the diagnosis. Okay? Just to tell toxic multinodular goiter and keep quiet during diagnosis. Okay? Is it clear? Sai, Shruti, Sangeeta? So, sir, anything to
Yes, sir.
comment? Robin, Manoharan, sir? Keshav, I think. Next. Next slide. So, I just go through the investigation. Sai or Sangeeta? Sai.
Sir, I am starting investigation, sir.
Okay.
Investigations, routine investigation, complete blood count, blood grouping, RS typing, blood sugar, serum urea, creatinine, urine albumin sugar, RFT, LFT, viral markers, chest X-ray, ECG, echo. Specific investigation like
It's a
thyroid.
blood urea and serum creatinine. Serum urea is not there, I think. Just to confirm, you can ask in biochemistry. It's a blood urea and serum creatinine.
Yes.
Wording just to clarify. Okay. Urine albumin,
Yes.
sugar, RFT, viral marker, chest X-ray, ECG. TF3,
Specific.
serum TSH, T3, T4. Okay. What's the normal value TSH?
Sir,
Normal value
TSH.
TSH?
0 to 5 international units by ml, sir.
Is
can give. Now current contraindication is less than 5 years. In this patient, absolutely no contraindication. But here there is a in the nodular goiter, it is of no use. Okay, because nodules are.
Yes, sir. Don't try those.
Okay, that's why you can't. That's why you have to do the total thyroidectomy. So here treatment.
Sir, we are live again.
You are not okay. You are whatever you are discussing. Next slide.
Next slide, sir.
Next slide, Sangeeta. Lavanya, next slide. Lavanya, next slide. So anti-thyroid drugs
treatment.
And she has already told the patient with thyroid and then total thyroid. Here we can't give radioactive therapy because nodules are there. And you can't continue anti-thyroid drugs because nodules will not reflect. Okay? So total thyroidectomy is the answer. Why you want to make the patient use thyroid?
Sir, to prevent thyroid storm condition, sir.
Thyroid storm will occur. Always make the patient use thyroid in a toxic goiter. In a toxic nodular goiter, surgery is the treatment. Okay? Suppose this is toxic adenoma, only one side is there. What option you have?
Sir,
only
toxic
one toxic adenoma nodule is there.
Right, toxic adenoma.
What option you have got? Hi, Shruti, Sangeeta.
Sir, that time also we have to do total thyroidectomy because recurrence is very low compared.
Is autonomous functioning gland, no?
Yes, sir. Autonomous.
You are retaining the normal gland which was not functioning. It will function once you remove this one, other side. So you don't require to give a thyroxine supplement maintenance dose to that patient. Everything will be okay.
Yes.
And hypocalcemia chances also will not be there. So all those added advantages are there. Definitely, if it is a confirmed toxic adenoma, chemotherapy is sufficient. So radioactive therapy is sufficient. Okay. Otherwise, you have to do hemithyroid. Here it is total thyroidectomy. Right. So, Robin, anything to add, sir?
Yes, Sangeeta, after total thyroidectomy, what happens? No thyroxine.
Sir, after we have to supplement thyroxine for lifelong, sir.
That you have to mention.
You have to tell maintenance dose supplement with the maintenance dose of thyroxine, lifelong. How much was the dose?
So 0.3 mg OD.
0.1 milligram or 100 microgram. You have to give before. Robin, anything to comment?
Sangeeta, maintenance versus suppressive dose. Two different. 0.1, 0.3. Where do you use suppressive dose, high dose that you just said? 0.1 is minimum, 100 microgram or 0.1 milligram?
Sir, 0.1 milligram
minimum
is used.
Maintenance.
Suppressive dose, where will you use?
Suppressive dose in case of long-standing MNG, maybe goiter is present, means we have to give suppressive dose.
No.
Post-total thyroidectomy. You've removed the thyroid.
Yes.
The whole thyroid is removed.
Right, Shruti? You got any answer? Suppressive dose. In which situation you give suppressive dose of L-thyroid? It's more. 200 microgram, 300 microgram, 0.21 milligram. In malignancy, when you operate on differential thyroid cancer, whether you are because your thyroid, mainly differentiated, mainly capillary, of course DTC. After total thyroidectomy, you can give radioactive therapy also. After that, once you finish all three treatments, always keep the patient with suppressive dose of thyroid. The TSH is suppressed fully, so that recurrence will not occur. It's higher dose, like around 0.3 milligram. You have some subclinical toxicity. Okay, so suppressive dose is for malignancy after thyroidectomy. Here, all benign. Here, maintenance dose. It is 100 microgram before food. Okay, this one is a food doses. Maintenance suppressive doses. Okay. So, sir, anything to answer? Anything to question? Next, sir, you want to question and ask any questions, sir? Manohar sir, Robin.
Nothing, sir. You have covered all.
Robin, final comment. Lavanya, put on my slide.
Yes, the presentation was good. I think next time the background sound should be a little bit less, I think, in the hostel. Because yeah,
Hostel friends are talking outside.
yeah, there's a lot of noise.
Too much noise.
When you present a case, especially endocrine system, surgical case, swelling is very important. It should be full paragraph. Site, onset, character of it, because the extent and character is very important. The evolution of the goiter is very important because we want to know from where to where, what is the size. The relieving aggravating factors, okay. Then again, pain. Pain, when it comes to, there are only two conditions where pain is important. When the benign things like thyroiditis and malignancy. Okay, these are two things. Then you cover symptoms of hypothyroidism, like you perfectly said, symptoms of hyper, symptoms of hypo. Then you go to malignancy, metastasis. So endocrine system should be 1.5 pages. Whether it's UG or PG, it should be full because we want to know how much you have taken history of the patient. Okay, and what you've done is a slight error is you have given us few lines of spelling, then you went to negative history, then you went to the next complaint to the next page. Keep your presenting complaints complete, then you go to the features, then you go to the negative, so it will be complete. And investigations is fine actually, it's all in order. And treatment, patient is thyrotoxic. Make the patient euthyroid, antithyroid drugs completely, which are the drugs you need to know, basic dose at least basics, including propranolol, other than carbimazole, methimazole, and propylthiouracil. And a role of radioisotope scan. There are two types of radioisotopes that you need to know. Which is the most common radioisotope that you will use? Sangeeta or Sai? Anyone? Most common.
Iodine 123 and technetium, sir.
Yeah, these are the two types of most commonly used would be technetium for two reasons. One, very cost effective and very low radiation.
Not off-life, sir. Only 6 hours is off-life for technetium, sir.
Yes, so technetium, very low dose is enough and it is cost effective. And your report will be very quick compared to the radioactive iodine. Okay, so that's that. And last one is everything is over, you go to the thyroid ectomy of the patient is euthyroid. And complications thyroidectomy, two common things, hypoparathyroidism and nerve palsy. So I think, yes sir, they have covered the whole topic here.
And examination method or little bit order, present history and other things. Otherwise, overall they have answered well, sir, presentation, everything.
Yes,
sir. So, Ganesh sir, they have presented well.
Thank you, sir. Thank you, sir. Thank you for your time.
I'll just go through my slides quickly in 5 minutes, Robin. Next slide.
Yes.
Next slide. Lavanya, next slide. So history is occupation, all these things are that important. So your male patient, they are high risk, remember, for malignancy. That's the point you have to remember. You said butterfly shape, that's how exactly it looks like. So different nodules, all those things are commonly in mind. So male thyroid is uncommon, but they are dangerous. Remember, they are always high risk. Next slide. So this is only endocrine gland. Remember chief gland, back pain, hoarseness, weight loss, weakness, palpitation, tremor should come in the chief complaint, which we have not mentioned, Sangeeta. It should come in the chief complaint always. Okay, this is how exactly it should be. If it is negative, don't write, but whatever positive, you should write. Okay. So next slide.
Thanks.
Next. Lavanya, next slide. Okay, this is just in this one, swelling, pain, fever, other lump, skull, pressure symptoms. This is exactly other exactly sir, Manohar sir has told. Pressure symptom, toxicity, hypothermia, like that, orderly put. Understood? As all these things are pressure symptoms, past history of swelling, you have discussed that. Treatment, surgery, thyroxine, antithyroid drugs, other drugs. That all those things we have discussed, same thing we have put. In females, important, menstrual discomfort is important. Family details, diabetes, malignancy treatment. So next slide. So examination, eye signs. Sir has clearly mentioned that eye signs, if not eyes are normal. Right, it's most important. Tremor in the hand, tongue, gait, sleeping pulse, that is again very clearly we have discussed availability to check why you want to check during sleeping. And these 5 signs which I have discussed, Moncrief, Del Valle, depression, and Mobius, Joffrey signs. You should know how to do that. Next slide. Next slide. Next. So this is the moment if the depression you should mention first actually. You have mentioned last in slide only. You should come first. And whether it had Bigelow method, some trials method you have to mention, Bigelow's, Hawker's, Leahy's method important. You have to mention that in your case sheet in the palpation. Not miss it. Pulsation, thrill in the superior pole. You have discussed the pain of the swelling. I think you have mentioned contraction of thyroid muscle. And the controversy about mobility is clarified by Robin actually. Proximal distal swelling, sympathetic change, hereditary. Sorry, this is for next. Next. Okay, oral. Oral cavity mainly for the retrosternal extension. Lingual thyroid. Scalp is important. Over the swelling we have discussed, cervical lymph node, level 2 OB34, understood? No, secondary lymph node, size to the, this is what important. And in the toxic thing, ankle jerk, knee jerk, ankle jerk will be exaggerated, so you should know if somebody asked. And skull spine for the metastasis. So next slide. Next. So multinodular go back. So non-toxic, toxic. Go to club usually, like what I told. Quadruple evaluation here, FNAC in toxic thyroid, not otherwise it's quadruple evaluation. Triple assessment for the breast, quadruple assessment for the thyroid. Remember, clinical, sonological, FNAC, biochemical. This is the quadruple assessment. You should tell first this one. Next slide. Next. So this is important. Give a water, lower border, butterfly shape. Trials method, contrast thyroid muscle. Next slide. Next. So, from beginning you are examining, then trials method, trachea. Already Robin has shown tracheal deviation to check. Next slide. So, this is the pre-tibial mixed edema, toxic thyroid. This is the Leahy's method. This is the Mobius, is a Moncrief sign, Mobius sign, and the thrill to palpate in the upper pole. This is the North-Ziger sign here. This is the Joffrey sign. So different. These are the few signs which you have to remember. Actually, these 5 signs. How exactly to do? Next slide. And again, nodular goiter. See that? Okay. Different types of goiters. Next slide. Next slide. Here you can see malignancy, and you can see the lingual thyroid here, posteriorly the tongue. How exactly it looks like? Next slide. Next. So remember all these things where now we have discussed like functional status, compression, neck lymph node, tracheal deviation, features of malignant external extension, cardiac we have discussed properly, bone secondary, trials method, trials grading, both we have discussed. Serum calcium is important. We have forgot to mention actually in the blood. Because if you are operating, calcium is important. Basal calcium level should know. And thyroid antibody X-ray we discussed. Radioactive iodine study for want of time we didn't discuss. Serum thyroid mainly for malignancy. All these things for thyroid you have to remember. Thyroid steel, paradox, lateral level, that's a misnomer. It's a malignancy. Different eye size. And rapid decrease of thyroid, why anatomy, go back. All these things are various ligament, various sign, lingual therapy, table with exophthalmos, causes of goiter, classification. All this is important. Next slide. I'll just go through the toxic in 2 minutes. Next slide. Next. So this is the classified thyrotoxic courses. Differences already we have discussed. Just often they will ask you MCQ. Primary is the Graves' disease. Second is the plumber disease. Toxic adenomyosis. Weiss disease. All these rare things may be asked. Not mesodoid fat, type of function, weak parathyroiditis, neonatal, summa ovary, and metastatic rare, but can occur. Drugs mainly amiodarone is the one anti-rich cause of the toxicity. This drug you have to remember, especially in MCQ. Which drug causes the toxicity? Anti-arrhythmic drug, amiodarone. The real toxicity, actually. Remember the next slide. Next slide. So T3 toxicity is the important thing because T3 is increased and other things are normal. So T3 will be we have to assess. Subclinical is the most important thing because it is unnoticed many times and untreated. And this untreated subclinical causes the cardiomyopathy and arrhythmia of late. That's why because these people go for cardiomyopathy because not treated because they think that only TSH is decreased, so it is not necessary to treat. But eventually they will have a lot of complications because untreated toxic thyroid will have cardiomyopathy complication. Struma ovariae, ovarian teratoma causing it. What is struma? Sometimes they'll ask in MCQ. Struma is in Bulgaria, where river flows in the Aegean Sea. Struma means whiter. Hashimoto's Hashimoto's thyroid. Next slide. So all these are the treatments. I'm not going to discuss the more common in females. Grave disease is the primary one, and these are symptoms appear first, then swelling. And secondary one, swelling appear, then symptom. So that point you have to now listen to remember to differentiate. So thrill, all those things. I'm not going to discuss that already. We have discussed. This slide is important. Next slide. So again, symptoms and signs. Symptom for toxicosis, signs. These are the GA symptom. Sir has already discussed that. CVS symptoms, skeletal system, genital amenorrhea and other things, abdomen, hair loss, gynecomastia, all those things. Psychiatrists, sometimes many times psychiatrists treat them without doing the TSH level. Known it is because they will be nervousness, insomnia, all those things. So later when they do the thyroid function test, they'll understand, find out that it is not psychiatric problem, it's actually toxicosis. So sympathetic overactivity, all these things we have discussed, myopathy, everything due to that only. Fine tremor is the diffuse little bit of the gray matter. That also we have discussed fine and coarse tremor that Robin had discussed that. So symptoms are like this. Next slide. Next. So signs are eye signs. All these signs which we are not going to discuss that, of course, is important. Not every sign. These are 4 or 5 signs you have to remember how to do that, what interpretation you should know how to do. And grading is example, grade, severity, malignant test with the misnomer is not malignancy, but vision will be lost. So treatment is steroid. Rituximab is the current drug of choice, important drug for the exophthalmos. Remember, it's the MCQ question. Rituximab is used now for exophthalmos, especially severe exophthalmos. Next slide. Next. So sleeping pulse rate already we have discussed. How exactly, why exactly, all those cardiac manifestations. These are the things which we have discussed already in detail. While I think myopathy proximal arm and thigh again, Manohar sir has discussed that. This is another thing. Thyrotoxic hypokalemic periodic paralysis can occur in the primary toxicosis. Pre-table mixed edema is a different thing. Dermopathy, acropathy, all those things are different things to look for. Next slide. Next. So investigations, quadruple assessment in a toxic thyroid FNAC is a query. So we all discussed that when you will do FNAC. Once you controlled nodular goiter, you can do FNAC in a very large goiter. If you're suspecting malignancy, then only you do FNAC. After sonology of this site, they say I put option mark to the quadruple assessment in the toxic thyroid. So thyroid like radioscopy has got some role, not in every patient currently. Now, 99 metastable technetium is also very useful for diagnosis, not therapeutic. Iodine 134 for therapy. You have to remember half-life iodine 123, iodine 131. Iodine 130 is around 8 days. Iodine 123 is around hours actually, 23 hours, something like that. So remember, this is asked as the MCQ question. Next slide. So treatment is relief of symptoms. I'm not going to discuss beta blocker and calcium channel blockers. Oral rehydration is important in this patient. This is very important. Next slide. Next. So antithyroid drugs, why you want to do? Release of hormone, logorthiodine, methimazole, carbimazole, propylthyrosol. It got its own indications. I'm not going to detail that. Propranolol is a very useful drug. When there is antibody production, steroid, all the things are quite again useful. Steroids may be useful in such situation. So they have exactly categorize and treat the patient. Now currently many people use methimazole. We commonly use, surgeons use carbimazole. There are special indication for propylthyrosol, of course. Next slide. So all these are the indication for toxic thyroid, antithyroid drugs, toxicity. I'm not going to detail that. So it takes 8 weeks to become euthyroid. So regular assessment is important to titrate the dose and continue. After surgery also you should continue for 7 days because the thyroxine half-life is 8 days, 7 to 10 days, then you stop it. Then for after radioactive therapy you have to give for 6 weeks to 12 weeks because radioactive to control the toxicity takes 3 months. So until then, you have to give antithyroid drugs, then titrate it and reduce it and stop it. Next slide. Next slide. So complication of antithyroid drugs, main thing is granulocytosis. So if it is sore throat, to stop the drug, it takes 2 weeks to aglocytic control. You may have to give a penicillin. You have to monitor sometimes granulocyte stimulating factor. You have to give. In severe cases, you may have to admit and treat. So this is prolonged treatment complications. And size of thyroid, if it is a nodular toxic goiter, it may not. It is useful mainly for a primary toxic goiter, but nodular thyroid, it may not regress. But you have to make them euthyroid before starting any definitive therapy. That's why it is very important. Next slide. Next. So radioactive is very important. Primary to recurrent of autonomous toxic nodule, and it's a preferred method. So all these things are the process. So then you have abstinence. Isolation is important in this patient. Usually it's given orally, remember, not injection. Hydro 131 comes as a capsule or liquid. So give it orally. But only thing is, for around 3 days, they have to isolate them. Olden days, 7 days, now 3 days. Isolation is important. So, but it takes 3 months to completely have a complete efficacy. Until then, you have to add on 10 thyroid drugs. Then switch over to the thyroxine because they go for hypothyroidism. Next slide. So, given oral as capsule liquid form, not recommended to the patient with severe ophthalmopathy. Ophthalmopathy will not regress. Not advisable chronic smokers. They have to quit smoking. If you are radioactive therapy, pregnancy, breastfeeding, recent lactation are contraindicated. The contraindications for radioactive therapy. Remember. Next slide. Next. So thyroid is the main choice, especially in nodular goiter. All these things are the indications. I'm not going to discuss. I'm not going to read these indications. You can see the slide. Next slide. Next. It's a total thyroidectomy. Remember, olden days we used to do partial, subtotal. Now currently total. In autonomous nodule, hemithyroidectomy can be done. Of course, equally radioactive therapy is also equally effective for the autonomous nodule. Now, these are the disadvantages of this recurrent toxicity, thyroid insufficiency, myxedema, and of course complications, hypocalcemia, recurrent lung injury, and so on. Next slide. So this is the Emil Theodor Cocker, was the first surgeon to get Nobel Prize in 1913. A pioneer in the thyroid surgery. Cocker, so many Cocker test, Cocker's test, Cocker Savine, Cocker's incision. So many things are there. He got Nobel Prize. There are only 4 surgeons got Nobel Prize until now, sir. Very less number, sir. So that is about great honor person actually. Emil Theodor Cocker from Switzerland, Bern, Switzerland. 100 years back, he did extensive work on thyroid diseases. For that purpose, he got Nobel Prize. So that is a briefly about toxic thyroid. You can read my book and clinical book. Next slide. Next slide. Next. Next. So thank you everybody. Go back. Thank you everybody. Sir Ganesh sir, thank you for joining us.
Thank
Sir,
you,
my
thank you,
guru,
sir.
and Kumar sir joined. So I request all students to subscribe my YouTube channel. It's free, no cost for that. Already around 500 lectures are there. So many live sessions we had already. Robin and Manon sir are the main backbone for me for these live sessions. Ganeshan sir, also thank you for joining this live session. And my clinical book and manual 8th edition has come. My guru has written the foreword. Manon sir, written a foreword. Thank you very much. Robin also always with me all these times.
So to conclude, both Sangeeta and Sai both did very well, sir.
Yeah, they have presented very well,
Very well in detail, and
difficult to present. Both
in between,
Sai and Sangeeta.
occasionally they were a little scared. Otherwise,
They presented very well.
discussion was good and very neatly, very say from the beginning.
They were very sensitive, sir. All
Very
questions.
sensitive. Narration is very good, sir.
Good answer.
So, best wishes, both Sangeeta and Sai.
Thank you, sir. Thank you, sir.
Presented well.
Thank you, sir.
Ganesh, thank you, sir. Thank you for
Sir, thank you, sir. Thank you, sir.
Thank you. Robin,
Thank you, sir.
Thank you, sir. Good night. Good night.
And all viewers, thank you very much. Good luck.